Hello everyone, and welcome back to the second part of our Pet Family Workshop lecture. Typically what we would have done in between our two lectures is we would have had a bit of a break. We would have given you some snacks and some coffee and tea and had a chance to chat a little more informally about questions and concerns. And again, it pains us that we're not able to do that this year to provide you that more informal type gathering, but we still think it's really important that we can give you this information and so that we can have a discussion when we do get together in the interactive online portion of our workshop at the end of this month. This talk is really going to be about the medications that we use, but before I start talking about them, it's important that we understand a little bit about what's going on in the brain during a psychotic episode. So I'm going to give you a little bit of information that'll make understanding what the medications do a bit easier. So as I'm sure many people know and have heard and may have had some personal experiences with, the brain is an incredibly complex organ that is in charge of so many of our body's functions. When we think about the brain, we tend to conceive of it like the picture on the left, a big gray blob with lots of folds, kind of sitting there looking like jelly. But really a much better way to think of the brain is more like the picture on the right. It's an incredibly intricate system of networks with information and electricity being constantly passed from one part to the other. It really is the original internet, so to speak, that I think our actual internet can't even come close to. So it is an organ that houses cells that are constantly communicating with one another and sending information from one location to the other, sometimes close, sometimes far. So when I think of the brain, this is really what I think of. It is an incredibly busy freeway full of traffic, on-ramps, off-ramps, some cars going short distances, some cars going far distances. And the cars in this instance are really the communication happening between all of the different cells in the brain. Some of the trips are, again, very long and convoluted, and others very direct. But all of the cars need to get to their destination in order for the whole to operate properly. And the cars, when it comes to the brain, are what we call neurotransmitters. They are the vehicles of the information that allow the cells to know what's going on. So there's many different kinds of neurotransmitters, just like there's many different kinds of cars, and they're all a little bit different, but they all essentially work the same way by traveling from one brain cell to the next and providing some form of communication. So if you were to look up very close between two brain cells and see what was going on, you would see that there's a chemical distance being traveled by these neurotransmitters from one cell to another. That again allows for some information to be processed so that the part of the brain can do what it is meant to do. Neurotransmitters are vital to our brain's function. These brain vehicles control every aspect of our brain's function, from things like our internal temperature control, our sleeping and our dreams, the ability to move, our thoughts, our mood state, and things like our memory or attention. All of these things rely on these neurochemicals working correctly. The one that we're going to focus on mostly today is one called dopamine. Dopamine is a really important neurotransmitter, and it's vital for many brain functions. Dopamine is key in movement, so to be able to move in a fluid way without any tremors or rigid movements. You may have heard of an illness called Parkinson's, and in that illness, there's a different problem with dopamine, and people have difficulty moving in a fluid and usual way. Dopamine is also vital for our cognitive functioning, especially for things like memory and attention. We need dopamine in order to have this ability to learn and then retain information. Dopamine is a key player in our emotions, and these are both positive and negative emotions. Dopamine plays a huge role in fear and awareness of our environment and feeling kind of on edge, and we'll talk a little bit about that as it applies to psychosis. But on the flip side, in other parts of the brain, dopamine plays a huge role in terms of pleasure. So it's the chemical that releases the chemical pleasure parts of our brain when we do something that we enjoy, whether it's eating, a decadent food or engaging in a favorite activity or being with someone we like. Dopamine helps us respond positively in those situations. And for all aspects of learning, dopamine also plays a huge role. So when we look at what dopamine does in the brain in terms of these freeways or pathways, like I was talking about before. There's many of them, but the key ones that we'll focus on, these dopamine freeways or pathways, these are the ones that are relevant to psychosis. And we'll come back to the slide in a little bit when we want to talk about some of these pathways. But the two that we're going to focus on right now, the one on the right is called the mesolimbic or the limbic pathway. And that's the pathway that gets disrupted when people have delusions, hallucinations, and very disorganized behavior. And then the one on the top left, the mesocortical pathway, that is the pathway in which dopamine helps to regulate our thinking, our functioning, our ability to multitask. And so when that's affected, we see people get those negative symptoms we talked about in the last lecture: lack of motivation, lack of drive, lack of spontaneous doing things, talking to people. And then later on, when we talk about side effects of medication, we'll talk about those two pathways on the bottom, which are implicated in some of the side effects of our medication. So this is a picture of some of those brain freeways and that dopamine would travel. And we'll talk a bit about what happens when it gets disrupted. So the first one, that one that was on the top right, the limbic system, that's the part of our brain that tells us how to feel about things, and also to make sure that we notice things and remember them if we need them for survival. It's one of the oldest parts of our brain, and it's shared by all mammals. All mammals have very similar limbic systems to ours, because for really any species, being able to notice something, register it as maybe a danger, and then avoid it later on is a key survival skill. So here would be an example of why the limbic system is important. These rabbits are in a burrow, they're pretty close to that fox, and probably something in their brain is telling them right now, there's something not right about that other creature that's looking at us. We should probably be afraid, we should probably run, right? That instinct, that fight or flight instinct, that fear is triggered from the limbic system and then informs the brain what you should do about it, right? What we don't want is very lackadaisical rabbits to look at the fox and say, he's cute and furry, he's probably fine, right? We need their brains to correctly register that this is a predator. And this is a key survival mechanism that we all have. The problem, though, is that in psychosis, the limbic system really goes on overdrive. So all of a sudden, for somebody who's in psychosis, everything's a threat, right? It could be something as innocuous, like that example I gave you of my gentleman who's afraid of people wearing their ball caps backward. To him, that's a real and present danger that he needs to do something about. And that's his brain telling him that, right? It's not an opinion. It's something his brain is completely saying to him, this is not safe. You have to get out of here. And so in this case, the limbic system is triggered and is triggering fear. And then making someone make associations and connections where there should be none. And that's why we see these delusions and ultimately people respond fearfully to them and act in that way, and they feel completely real. That other system we talked about, the mesocortical system, the one on the top right in that diagram, this is one that is highly developed in humans compared to other mammals. And this is why we have a greater capacity to learn, to read, to study, to make associations compared to other animals. It's responsible for how we organize our behavior, how we motivate ourselves to get things done. And when this pathway is disrupted, as we see in psychosis, this results in a decline in ability to think, multitask, learn, and organize behavior. And this is why we see that the negative symptoms come out in addition to those other more acute symptoms like hallucinations and delusions. So this is why dopamine is important, and these are two of the major pathways that we know problems occur when we see the symptoms of psychosis. Having said that, it's important to keep in mind that abnormalities in the dopamine system is what we now know just one of many changes that have happened in the brain in individuals with psychotic disorders. We know that other neurotransmitters, other pathways, other parts of the brain are also involved with some of the symptoms, but we don't have effective treatments for those areas yet, especially when it comes to the cognitive symptoms of psychosis and some of the earlier warning sign symptoms that we're currently studying to understand better. We know that it's not just about dopamine, but we don't have effective market-ready treatments yet, although certainly the research that's happening, including the research in our clinic, we hope down the road will lead to better, more comprehensive treatments for these other aspects of what happens in the brain during a psychotic disorder. So knowing a little bit about what goes wrong in the brain in a psychosis, what should antipsychotic medications do? Well, ideally, they should help to alleviate the psychotic symptoms. They should help to improve what we call the negative symptoms. They should help cognitive functioning, help improve mood, and most ideally not cause any side effects. We're going to talk a little bit about which of those our current medications meet and which ones they fall a bit short on, but this would be the ideal, that we're able to treat all symptoms and not cause side effects. Here's some pictures of many of the medications that we use. You see here that these are tablets. The top right would be examples of injection medications that are long-acting, so people don't have to take pills every day. And we'll talk a little bit more about that. Let me stress, though, that the need for treatment with medication is very high. What we know is that if somebody stops medication within the first year, the relapse rate is very, very high. So if somebody stops medication, the chances of recurrence is 75 to anywhere up to 90%, whereas the chances of recurrence if somebody continues on medication is closer to about 3%. And that's some large-scale Canadian research that was done that is very in line with research that we see in other parts of the world. Research consistently puts medication non-adherence, so not taking medication, as the strongest predictor of relapse. In large studies, these are the four things, kind of family feud style, that have been found to increase people's risk of relapse. So number one is being not adherent to your medication. Number two is using substances on a regular and persistent basis. The third one is what we call carer's critical comments. So if somebody is in an environment once they're out of their psychotic episode in which they feel devalued for having a mental illness, that actually does increase the risk of relapse. And the last one is what we call poor premorbid adjustment. So that's just if you had significant struggles socially, educationally, or with your mental health prior to the psychosis, it's likely going to be a risk factor for relapse even after the treatment of psychosis. So how do antipsychotics work? Well, they work by blocking the amount of that dopamine neurotransmitter available to brain cells by stopping it from entering the cell. So if you look at this picture, you see the dopamine is being produced and there's too much dopamine being produced, and that the dopamine receptors would otherwise be taking it up and the dopamine would be overactive in some parts of the brain and not working well in others. But that the antipsychotics, which are the kind of little red dots there, actually block the receptors so that the dopamine, the extra dopamine that's around causing some of these psychotic symptoms, can't be taken up by the other cells. So that's our understanding of how the antipsychotics work. But more does not equal better. So as we've seen over several decades of research, you only have to block the dopamine receptor somewhat for that antipsychotic to take effect. And in fact, if you go beyond a certain limit, you get significant side effects. Things like muscle stiffness, tremors, being very fatigued, things like sexual side effects, and even lactation in both men and women. So it's a really delicate balance of blocking some of the dopamine enough to take away some of the hallucinations, delusions, and other symptoms, but not so much that you're stuck with significant side effects. So if we come back again to that picture we saw earlier in these dopamine pathways, we want to make sure that we regulate or control the amount of dopamine that's causing the problems in those upper pathways, the mesolimbic and the mesocortical pathways. But we don't want to cause so much dopamine blocking that we get side effects in the other pathways. The one on the bottom right It's called the nigrostriatal pathway, and that's the one that controls our movement. And people with Parkinson's disease, they have dopamine problems in that area that can cause tremors and muscle stiffness. And what we see if we use too much of our medication and we block dopamine too much, we can actually create some of those side effects that look similar to what you might see in Parkinson's. The newer antipsychotics that we'll talk about have much less of a risk of this, but still possible. And the bottom left is a dopamine pathway called the tuberoinfundibular pathway, nice long word, which essentially regulates lactation, and that can be turned on as a side effect and can cause lactation in both men and women. Antipsychotics have been around since the 1960s, and over the years they've attempted to eliminate the problems with them while keeping the effect, the good effects or the benefits that we've had with them. So they're divided into three generations. The first generation of antipsychotics were discovered quite by accident in the 1960s. They are very effective dopamine blockers, but because of that, they cause side effects, significant muscle side effects, as well as side effects on the cardiovascular system, like increasing the heart rate, decreasing blood pressure. The names of these medications are things like Haldol, Clopixol, Loxapine, and Fluanxol. Now, we still use these today. We use them in our emergency room, up on our inpatient ward. And some patients ultimately prefer to use these medications ongoing for different reasons if they want to avoid the side effects of the other groups. What we've learned is that back when they were first used in the 1960s and 70s, the doses were way too high, completely inappropriate. Now that we understand how dopamine works in the brain, we understand we can still have the same positive effect on a fraction of the dose. So although it's the same medication, people now have many less side effects on these medications than they would have back 30, 40 years ago, because the doses we use now are much more conservative. In the 1990s, in response to demands for antipsychotics with better side effect profiles, specifically with less muscle side effects, the second generation antipsychotics came on the market. These were designed to have less muscle side effects, but there was also this hope that they could improve both the negative symptoms like lack of motivation, social withdrawal, as well as some cognitive symptoms of the illness, in addition to acute psychotic symptoms. In terms of how well they did those things, they treated acute psychotic symptoms as well as previous medications. Not a lot of evidence that they really treated negative symptoms or cognitive symptoms. But the trade-off, though, is that these medications overall did have more of a risk of sedation and weight gain, and for some of them in particular, significant weight gain. The names of these medications, I have the trade name and then the generic name in the brackets: Risperdal, Risperidone, Seroquel, generic name Quetiapine, Zyprexa, which is olanzapine, Zeldox, which is Aprazodone, and Invega, which is paliperidone. In particular, olanzapine, Quetiapine were the ones that caused significant weight gain. It's important to note that these medications did not treat the psychosis any better. Multiple trials have been done to show that they are no better at treating psychosis than the first generation medication, but it's a different set of side effects. And so for some people, the side effects were improved if they were prone to the muscle side effects, but for other people where weight gain was an issue, you couldn't really say that it was a better side effect profile. And so again, as time and research went on, the goal was to find antipsychotics that could avoid all of those side effects, both muscle side effects and weight gain. And so in about the 2000s, we started to get what's called the third generation antipsychotics. These were marketed to have really minimal side effects, and I would say that's true on a case-by-case basis. I would say for about a third to a half of my patients who take these medications, there's minimal to no side effects. The side effects of these medications tends to be restlessness, nausea, still some weight gain, but not nearly as much as the second generations. And these are the names of the third generation medications. So Abilify, Latuda, Safras, and Rexulti. Again, it's important to note that these medications are no better than the first generations at treating psychosis, but this generation of medications overall has less side effects. The other medication that we need to address is one called clozapine, which you've probably not heard yet. Clozapine has been used for several decades and has several common side effects. It has a high risk of weight gain, tiredness, some cardiovascular side effects like increased heart rate, dizziness from decreased blood pressure. And clozapine also has some rare side effects that need regular monitoring. At higher doses, it can cause seizures, and there can be a sudden drop in white blood cells that, if not noticed, could lead to serious illness or death, which is why we monitor and do blood work very regularly for people on clozapine. Why should we use clozapine? Well, because it works. Compared to all of our other medications, clozapine works much better than the rest. When somebody is not responding to at least 2 other medications, we turn to clozapine. And in that situation, it works well 2/3 of the time. In our clinic, we have a large clozapine clinic for individuals who are not successfully treated with the other medications, and we monitor them. We do regular blood work, blood pressure, and we dispense medications every few weeks on a calendar so that we can make sure that the blood work is being monitored. Really interestingly, of all of the medications, it blocks dopamine the least, but it's our best antipsychotic. So when I mentioned earlier that dopamine is not the only part of the story when it comes to psychotic disorders, I think the fact that clozapine works really well and we don't really understand why, even though it's our least dopamine blocking medication, tells us that there's a lot in the brain we're still trying to understand about the different aspects of psychosis. Weight gain from antipsychotics for some people can be very significant, especially if they're taking a second generation or clozapine. It can result in what's called metabolic syndrome, which increases both blood sugars and cholesterol. And for that reason, we do recommend regular blood work at least a couple times a year to make sure there's no sudden changes in blood sugars. It should also be noted that there's a small but known risk of heat stroke for individuals who take antipsychotics, especially for individuals who work outside, but really for all of us. We need to encourage hydration, cover with hats and shirts. The worst case scenario is someone who might be a roofer or kind of out all day at a festival, not wearing a shirt, not wearing a hat or sunscreen, and not hydrating enough. So the risk of heat stroke appears to be a bit higher in individuals who are taking our medications. So it's something to keep in mind, especially in these summer months. The medications don't work right away. The initial effects, like improving sleep and decreasing agitation, can be seen within hours to days, and the older medications have the advantage here because they are more sedating. Good response and good reduction in psychotic symptoms is usually seen within the first 2 weeks. It can take at least 4 to 8 weeks to see full remission of symptoms, though, so there is a wait involved. I always recommend, if possible, to start low and go slow. Sometimes when someone is very unwell, especially if they're on an inpatient unit or very agitated or upset, a temptation is to keep increasing the dose because waiting a week or waiting 2 weeks can feel like a really long time. But we know that our medications need time to work, and sometimes when we increase the dose too quickly, we can see a lot of side effects that we would avoid if we just waited a little bit. So keeping in mind, it takes several weeks to see full remission of symptoms. The last thing I'll talk about is long-acting injectable medications. Several of our antipsychotics come in a long-acting injection format. And our research demonstrates that most of us forget to take our prescribed medications consistently. This is all of us. The evidence would say at least half of us at any time are not taking our medications as prescribed. Now, when we do this talk in person, I kind of look around the room as I say that. There's always some guilty laughter as people recognize themselves in this statement. And certainly I myself am guilty of it, often running at the door in the morning and then not remembering later on in the day. There's other things we can do to help with that, things like dosette boxes or blister packs from the pharmacy, but the injection is really convenient because we know that even missing 2 doses a week of an antipsychotic is enough to increase the risk of relapse. Many of our medications are available in this way. Paliperidone comes monthly and every 3 months. Abilify or aripiprazole comes monthly, and then many of our first generation medications also come as a long-acting injection. The newer ones like paliperidone and Abilify are given in the arm, very much like a flu shot. The older ones require injection in the top of the hip because it's a bit of a different preparation. Again, we have a large injection clinic. Our injection nurse is very, very busy, and most of our clients prefer this format because they find it easier to remember. So another question we often get is, how long does someone need to stay on their medication? After a first episode of psychosis, individuals should maintain on medication for a minimum of 12 to 18 months, as relapse rates are highest in the first 2 years. And this seems like a really long time, but the evidence on this is pretty solid. And relapses can often be more difficult to stabilize than first episodes. So we really recommend that people maintain medication at least those 12 to 18 months. It doesn't mean that they have to stay on the same dose. For people that are doing well, we can often slowly taper down to what's called a maintenance dose, which is usually a lower dose than what was needed in the initial episode to settle symptoms. But here's the problem. We really don't have any ability to predict who might be in that very small group of individuals who can discontinue their medications. So it's not related to intelligence, it's not related to functioning, it's not related to what symptoms they had in their episode. So if there is a small group of people that can discontinue their medications, we don't really have any good predictors as to who they are. The conversation I usually have with my clients at the end of the 18 months or so is some of them will say, look, I never want to go through that again. Going through a psychosis was really traumatic. If the odds are high that I'm going to relapse, I'd rather stay on a very low dose of medication and not go through that again. I have other clients who say, look, I have to know if there's a chance I can be medication free for the rest of my life. I'm willing to find out the hard way, even if symptoms come back, to know whether or not I can come off medication. I can understand both of those responses. I think both of those are what we call informed decisions, because in both of those responses, the person shows insight into the fact they've had a psychosis. But remember, medication is just one component of treatment. This has been the medication talk, but much of what we offer at our clinic is in tandem with our medications. Unfortunately, our ability to do this during the COVID-19 pandemic has been significantly hindered, but we maintain hope that we can bring all of our services back online. We have employment, peer support, groups, social skills training, many activities that clients can benefit from, so they don't just feel like all they're doing is coming to a clinic, seeing a doctor, and getting medication. Thank you very much for bearing with me during these 2 online presentations. We really want to have a chance to hear your questions and answer them. And so here's how we're going to do it this year during this novel format. You can post questions in the discussion portion of this YouTube channel, or you can email them directly to peptalks2020@gmail.com. The questions will not be answered right on the discussion board or directly by email, but we will take the questions and answer them in person in our live session. Some of them may be similar in nature, so we'll go through the questions and then give our answers to them in our live session. You're also welcome to ask your questions during the live session. There'll be opportunities to do that, and hopefully we'll have some good discussion. Just as a reminder, please don't provide any details in your questions that could compromise your loved one's privacy. It's okay to talk about a medication effect or a particular symptom, but please don't give any details that would make the identity of your loved one known, just for reasons of confidentiality. Again, we really thank you for your time and patience with this format, and we look forward to chatting with you on June 27th in our live session. Thanks very much.